So here's your suggestions on how to make your place, somebody else's emergency department and yours better, and things that you've done. Oh, geez. Eric says, we renovated the entire department for only $15 million. It doesn't facilitate patient throughput, but it's more fun to work in, and it's a lot nicer. The problem is we need more nurses, and there aren't. So I guess, so spend the $15 million and you'll be same place you were before, except it's more fun to work there.
How many nurses could you get for $15 million? Few.
Yeah.
I believe personally that I don't think there's a nursing shortage. There's a tech shortage. We should just hire more techs and let nurses do what nurses are supposed to do, rather than having them do everything, because some hospitals have this kind of view that, oh, this fabulous department, we have all nursing department, we've got rid of everybody else, like the LVNs and the techs. It's just stupid. Nurses should be supported. Every nurse should have a tech, don't you think? And wouldn't they do a lot more work and be able to focus on the right things and assessing patients and treating patients, rather than making phone calls, walk you to the bathroom, I'll empty your urinal kind of thing, where's a blanket, when's lunch? If you have only nurses, they're going to do all of that stuff, and that's certainly not $45 an hour work. And so there may be a shortage, but we got the wrong people doing the job, just like we have doctors doing things that they ought not do, and they should be facilitated by scribes and PAs and those kinds of things, so that they can become more efficient. The Philippines are empty. There are no more nurses coming, you know. But there's another way around it, but people have to have the idea of teching up really needs to kind of get sold. I think it's the way to go.
I have a good one. This one says, we post wait times online to our 2 EDs that are 10 miles apart. That's pretty cool. Who does that? Tell us about that. And
well, we just started it. We're hoping that one of our EDs has a significant lower volume than the other one.
yeah.
So we're hoping that, and it's a newer ED, so that a lot of the population in that area doesn't know that it's a full-out ED.
Interesting. So they see the shorter wait time, and potentially they'll go to the other one.
So you bump up the wait time at the one you don't want them to go to, so that they go to so you force them to go to the new place, kind of thing.
And how did you advertise that so that people knew that you were doing it that way? Do you guys have like a...
We have a marketing campaign,
Yeah.
and it's on our website. We actually have part of that marketing campaign is that people can actually text ER rate to a number, and then they get the ER rate times. And,
Is there an iPhone app for it?
we're working on that.
Yeah. Yeah.
So actually, I heard of a Texas facility where they had a billboard that had their wait times on it. All of this is pretty pathologic, though, when you think about it. If you have to, it reflects the reputation that we have for making people wait. It is a national reputation for emergency departments. And it's just a reflection of the fact that we don't value these people's business. If you really knew how much money they were generating, your administration would probably say, we got to fix this because we want more of these people. So this door-to-doctor time that people, you know, value very highly is, I think, probably the single most important time. And we just measured it at our hospital for the last year, and it certainly isn't exemplary, but it was 37 minutes. From the time they arrive to the time they see a doctor was 37 minutes, which, you know, I'd like to get it under that, but some ERs, it's, you know, that's ludicrous that they would be able to see a patient on average in 37 minutes from the time they arrive. No, that's not triage, it's not registration, it's from hit the building kind of thing. Do any of you know your doctor times? 14 minutes. 14 minutes? Is that 14 minutes?
Are you in the medical center?
Are your minutes the same as our minutes?
That's one of the 3 medical centers at Whistler, probably, yeah.
Do you have a lot of doctors or not very many patients?
Really good.
Modest guy.
Yeah. And
Their minutes are 90 seconds long. I think that's the issue.
What's your doctor's time?
Let me
So
just go ahead. I was going to say I want to go over something. There's a lot of them here. There's 8 sort of great things here, but what really impressed me is that 5 of them have nothing to do with the emergency department, and I think that's really, in terms of operational efficiency, where the problem is. It's most of the time, for big busy places, not us. It's always the back door. So I'll run through a couple, and we can kind of take them up. I'll take them in the order that I really like. One is nurses no longer call report. It's in Epic, or they can get it at the bedside when the patient comes up. You know, that's been recommended time and time again as a constant source of delay for admission, is that they call up and tell them the same thing that they're going to tell them at the bedside. They're going to tell them the labs that are going to come up on a report. And then the nurses on the floor always say, what? Sorry, the bed's not available yet. We're giving report. You know, there's always these things so that they can get through to the end of the shift so that the next group has to take it, sometimes legitimately because they know they have an intake process to do. But it's a classic slowdown part of it. There's a big consulting group that comes out there that says one of the other ways to do this is you agree on what a report is going to be to the floor. Nurses fill it out, you fax it to the floor, and 10 minutes later you just take the patient out.
Yeah.
None of that
We do.
stuff.
We do the fax report thing.
You do?
Yeah.
You do the fax report? Anybody else doing that? The don't call report kind of stuff. Good.
But we have a thing in our hospital I hadn't seen before, where the nurse calls to a number and, in effect, dictates the report. Not really dictating, but just leaves it like as a message, like a phone message, and then hangs up. And I hadn't seen that before. And the nurses were under the opinion in the ED that the ones on the floor never listened to it anyway. You know, which is very likely. So this way that we pretend to give report, they pretend to listen to it. I think though, isn't there a problem with the CMS or whatever is coming around, and this whole idea of handoff of patients? You know, they want us to do more reporting for that and to document that. Everybody here knows more about this, but isn't that right, that it's going the opposite direction?
Yeah, there is this big thing about the danger of handoffs kind of thing, but I don't know that it necessarily means, you know, a routine report on admission. It's like when one ER doctor leaves and another doctor comes on and takes the... We changed our handoff practice at the hospital where the doctors physically go to the patient's bedside, and doctor who's leaving introduces doctor who's coming and said, Mr. So-and-so, this is Dr. So, he's coming on, and I've told him what we're waiting for. We're waiting and where you stand in this process, so that you physically introduce this new doctor, because, you know, it's just kind of common courtesy. The idea of you walking in and said, I'm the new doctor, the other doctor's off, is kind of not the way you'd really like to do it if you were the patient. So we started that. There was, you know, everybody's grumbling about it. Oh, gee, I don't have time to do that. And now the nurses do it as well.
Here's a couple others in here that I like. Our nurse administrator who assigns beds is now directly responsible to the nurse ED director. So lines of authority, who works for whom. In a lot of places, I think it's said that you won't get this problem solved if you think, you know, this is the admission backup kind of stuff. You won't ever get it solved if people think it's an emergency department problem. Because then they'll say, the ED has a problem getting patients admitted, it's a hospital problem. An express admission unit to hold patients until a bed is available. So they're going somewhere, they're just not staying in the ED. Bed availability is in the computer. The ED nurse can look it up. So there's none of this, we're waiting to clean the bed kind of thing. Instituting a transport team to free up the ED nurses. Can't believe that ED nurses have to transport patients sometimes. Dedicated ED phlebotomists so that they free up the nurses as well. An ED throughput person hired to run computer numbers to see where the delays are, and the administration listens to that person. Interesting, we all know where delays are. I remember I had this one data project that I was working on where you could look at all the patients who had an x-ray by time of day and look at their throughput time by diagnosis. So you could say sprained ankles that get an x-ray by time of day, how long did it take them to get through the emergency department? And in this one place, every time from 12 to 1 o'clock, the throughput time went way up. Why was that? All the x-ray techs go to lunch at once. The director had known this for years. He'd been complaining about it for years. I showed him the graph, and that afternoon, they made everybody take lunch separately so that went away. So I think sometimes having data does things that just your own opinion doesn't help out. And then the best one, I think, saved for last year, they have a decreased nurse-to-patient ratio. It was 4 or 5 to 1, now it's 3 to 1.
That's expensive.
In California,
expensive.
you know, it's legislated how many nurses that you have to have per bed, and that was done by the nursing union. And so in the ER, we have 1 nurse for every 4 beds, and we are required to have a triage nurse even if you don't do triage. And that's required if you're there at 4 o'clock in the morning or 4 o'clock in the afternoon. So we have 4 nurses manning the 16 beds at 4 o'clock in the morning, which is utterly ridiculous. Our hospital's spending all of this money. So the idea of teching up and getting the right person to do the job, we can't afford it because we're spending so much money on these non-existent nurses because of the California Nursing Associations. I have no idea. We were really asleep on the switch when that came through.
I'd like to thank Kathleen here from St. Vincent's in Connecticut for a dinner recommendation at the top of the page there. It's not inexpensive, but very good. Mountain Inn in Whistler's Village. I like that idea. Thank you. I don't know.
So that should win, shouldn't it?
You know, it's as good as some. Number 1, hospitalist in the ED during the day shift to facilitate admissions into the hospital and decreased wait times for beds upstairs. If you have a busy enough place, in her place he's 70,000, you know, the hospitalist will be pretty busy. I think there's a danger with that it could sometimes slow you down. You know, when he gets behind by 4, you know, and, you know, you just want to admit him. He says, no, I haven't seen him yet. And similar things happen in hospitals with residencies if they have an admitting, like, medical resident who has to see the patient. That often becomes a bottleneck. But if you can do it, you know, with an attending, it sounds good. I don't know if other people have that. Second one, this is one that pisses us all off, doesn't it? Community physicians are strongly encouraged to direct admit patients bypassing the ED. Yeah, I mean, isn't it amazing how often we get phone calls? Oh, I'm sending this guy in. He's got this, that, and the other thing. We've been looking at it for a while. He had some blood in his stools. Why don't you admit him? On Monday, we're gonna do the endoscopy. Doctor, you know, doctor, GI doctor, why don't you just admit him? I don't have to admit him, you know. Now, I understand that there are times when the hospital's pretty full that somebody probably knows about this better than me, that they can't direct admit him. They say, I know there's no beds, we're only taking emergencies, and that's why he sends him into the ED. But that is truly bad. Does anybody have knowledge about this?
Well, there's another point of view that says all the admissions should come through the ED. You're going to get stuff done faster than is done on the floor. You're seeing the patient. You're going to tell the doctor, I've checked them out. Here's what we find, kind of thing. Everybody knows how sick this person is.
These are elective admitting. And what about an elective admission like that?
No, these aren't.
Yeah,
no.
That's
You know, if somebody has pneumonia in the office and they directly send them to the hospital for admission, by the time they get their blood cultures, we look at those patients disproportionately fall out of all of these time things because they go to the floor and it takes forever. So I would encourage doctors to admit their emergency cases through the emergency department that they're seeing in their office. I think that's one of the jobs that we do for the medical staff to help them out.
I think that's true. But I guess maybe you don't see it in the way that we do, where it's truly the GI case where he's been meeting with the scoper.
No,
he called
we don't
in
see
and said, okay, we'll do that on Monday, because we actually don't scope over the weekend unless it's an emergency. And I mean, these are truly elective admissions. They come through the ED. And, you know, at some point, all these things require your hospital administration. You can't do it as an ER doc, is
Yeah.
what it amounts to.
That creates an interesting problem, though, when you have we have a very overcrowded hospital, and we've talked about this, like try to prioritize the clinic admissions to avoid them coming through the ER, which is just more people in the ER. But then you say, well, but what about the people who are waiting in the ER for the beds? Shouldn't they be the ones that are prioritized? And sometimes it's difficult to decide which one is a more effective way to go, you know? We haven't solved that problem.
You know, I might as well start my rant on Joint Commission and CMS right now in terms of non-helpful things that they do and what could be helpful that they would do. Just think if it were a Joint Commission standard that said if there's more than, pick a number, 5, 10, 15 patients waiting in the emergency department, all elective surgeries must be canceled. If that were a Joint Commission standard, everybody had to do that, do you think they would fix the problem with bedding patients? I know plenty of hospitals that you have a GI bleeder in the emergency department. You've got to hold them there because they're doing an elective case up in the operating room a hip repair that they're going to send to that bed that you can't get your patient into. So I think when the Joint Commission is doing all this stuff about, timeouts and all kinds of crazy stuff and antibiotics within 4 hours that never meant anything, if they had this, that would work. The other standard they should have is that you would need to post on your website what percentage of your medical staff return their pages within 10 minutes, 20 minutes, 30 minutes, 40 minutes, because that's what slows us down for things. A lot of these workarounds, just get a bed. As soon as you think somebody needs an admission, get the bed, because then the delay is working them up and getting their doctor to approve it. So they've gone around that because they know their doctor's not going to call back for a while. To me, those would be Joint Commission standards that would work. Yeah, there was a comment.
In New York State, we have something similar to that, that hospitals are supposed to cancel all their elective surgeries if they're on delayed reversion. But it becomes a semantics game. We've got one in our city that regularly cancels everything at about 11 o'clock every night, and about 5 in the morning, they put them all back on the schedule. So.
And then I'll bet only administrators can put you on diversion, too. Right.
Okay, here's one. This one is from Steve. Through an empath recommendation, we initiated a 30-minute promise. Basically, it's an advertising gimmick to increase numbers. If you're not seen by a clinician in 30 minutes from check-in, you'll receive a $10 gift card. How it has seemed to help is that the charge nurses seem to have taken it personally to not give out the gift cards on their shifts. This seems to have had an effect on them being more hands-on with the nursing staff on pushing patients through the ER, whether discharged or admitted. That's interesting. Where's Steve? Steve, can you tell us more? How did that start? How's it going? How often do you give out the gift cards?
Yeah, Dan got come through. It was a kind of a lot of money, I guess, and then consulting how we can get through those times. Most of the places they kind of suggested it that we started things like that. I guess through the our advertising for the hospital, we set aside so much money to do this. They advertised for it for about 3 weeks on the not even news. The news stations actually gave free advertising, billboards, that kind of thing. We all had it. Nurses, a little ridiculous, and like, it's worked out okay.
So with the gift card, they can get one hospital dispensed Tylenol. Maybe a VDRL, something like that, whatever you
Yeah, I'll
want.
swap you a Tylenol. Give me the gift card back. Well, we had the 30-minute thing where you get movie tickets if you didn't get seen within 30 minutes, and we had a billboard, and the Department of Health Services in Los Angeles County saw that and said, we think that is misleading because some people may think they would be treated within 30, in and out within 30 minutes,
Cured.
which is
No, cured within 30
which
minutes.
is,
right. Cancer.
let's find the stupidest interpretation of this, and they basically made it clear that they didn't want us to do it in the future, to have that 30-minute time there.
It's inevitable that they would be disappointed when you set an expectation. I mean, you've set an expectation, 15 minutes, 30 minutes, whatever it is, and now you haven't met it. So, of course they're going to be unhappy with it. That's just human nature. Yeah.
No.
Wow, seeing them.
No.
I see it.
Yep, we've gotten your urine analysis cooking, and I'll be back. Yeah.
Or you know what you could say? There's a camera in each room. The doctor has seen you. He sees you fine. Yeah, you're wearing a button there. I think that'd be a good way to. Okay. There's a couple of interesting ones here.
No, it's just basically the introduction. Hi, I'm Dr. So-and-so. I'll be back to do your history and physical later, but let's get you comfortable. Just a good first impression.
Yeah, it's sort of like, the waitress, when they first see you, They don't even take the drinks order. They just say hi, you know, and that's
Yeah.
what you're doing.
Do you have a comment?
Drive-through. In Stanford did that when they were dealing with the flu. They tried an
Right.
experiment with a drive-through flu treatment. Oh, is it legal? Well, they published about it, and they did that experiment this winter.
Yeah, I don't see it's illegal. There are places where they have the communication thing, where the doc just does it through telemetry, not telemetry, you know what I mean? And that's okay. It's been considered, you can send bills for it. It's legal in that sense.
Yeah.
Before when you were talking about times, I just went down to Florida on a trip, and along a lot of major freeways, there's billboards that have their amount of times for their wait times. If you can text the number of minutes, it's like 12 minutes on their billboard, and you text a number to get your name put in line or whatever.
So you mean if you're planning to have an accident or something like that in the next few miles, you could get them ready. Yeah, be ready.
Can you text it to multiple hospitals, like you get reservations at restaurants, and see which one kind of comes
like,
through?
You know about open tables?
Yeah, it's
where you
like
make
open
that-
table.
It's very much like that. And you get points, and you can, you can in for new urinal, whatever you need, something like that. Here's a nice thought here. I haven't seen this before. This participant calls it streaming. So they have two teams. One is a likely admit team. The other is a likely discharge team. Okay, what does that mean, Peter? Is Peter here? Too bad. I don't know
He
what that
streamed out.
I guess
He was
that-
on the likely discharge.
I think what that must mean is that maybe a nurse triages to people, there's one side, if you're probably coming in, you go there, and maybe they have two docs working there. If you're not likely to come in, something like that. I haven't heard of it done exactly like that before.
Getting back to alerting people to the times, Joe, you have something here that I haven't seen where they have a big screen TV in the waiting room which informs patients of the waiting time per triage category and updates regularly as circumstances change ambulance arrivals. So you could say it's like the waiting list for your wait list for the airplane kind of thing. And if you're a gold or a silver or a thing, so please change my category. I want to move from this column to that column.
Yeah.
I feel I'm getting sicker. I've been under triaged.
I want an upgrade.
Does anybody remember the old movie Beetlejuice?
Oh, love Beetlejuice.
Beetlejuice, where they had the guy took the you are number 2 million to be seen, and another guy had number 1 to be seen, and he took it back. So you would go up and change it. I'm sorry, I really didn't sprain my toe. I really had chest pain. You just go up and change things.
Yeah, it must be kind of interesting how people interpret those triage categories. Like triage 5 probably says, you are a complete crock, 2 hours, 30 minutes, Triage 1, you're really sick. Triage 3, you're sick, but no insurance. And it just sort of gives those.
You want to give a $25 upgrade to move
Yeah.
up your triage category?
Or you could use points. You could use those points to upgrade.
You could have the maitre d' instead of triage. You just kind of get them the money.
How
Here's
about-
one I think Rick will like. Direct bedding for all patients when beds are available. This is the idea, why do you need to go through triage when you just put them in the bed if there's a bed? And they say, therefore, they used to have, it looks like, a north and a south unit. One was non-acute and the other was acute, sides of the ER. And they said, doesn't matter. You go to the bed that's available. And they liked it.
Triage is only done when you're full. Otherwise, just bring them back, just like all the VIPs. The VIPs, they don't go through that triage crap. They just come on, I got a bed for you, you sit there kind of thing. So we only do triage, even though we're mandated to have a triage nurse by the California thing, we only do triage when we don't have beds. And the other thing is, which means that you have to try to have a really quick turnaround time for the patients who are in those beds. So our goal has been 2 hours for a discharge patient and 3.5 for an admitted patient. 2 hours is not bad. I mean, it's pretty good. I don't know if you know what your times are for a discharge patient, but the whole goal is to get these people in and out as quickly as possible so you have the capacity to see more patients.
On that note, this old person also they have a triage nurse who sends suitable patients to a nearby primary care physician. Some of you might remember, it's a dangerous game to play. Well, I think if the triage nurse does the medical screening exam, which can be done, as long as it's done for everyone by a nurse, you can't separate it out like that. That's probably legal from the Cobra Imtala thing. But it's a strange, remember you see it was Sacramento, right? Davis tried this about 10 or 15 years ago when things were so busy that they would actually triage people to, to clinics. And this one's to a primary care doctor. So, a little unusual.
This one here, during the H1N1 surge, several of the administrative MDs came down to help. We now don't let them touch our patients. Josette, that's funny.
I like the alternative here is the hospital hired a CEO who was and is an ER doc. Finally, the administration was willing to use or implement processes we've been trying to implement for 15 years. I like that. That's the best possible one.
Well, that's important, though, right? Getting involved on the committees and things in your administration so that they hear your voice, they know what your problems are. That's a really important message. That's probably one of the most effective things that you can do as a department is sort of penetrate the administration, whether it's through committees or them getting administrative positions. It often makes a huge difference.
I think no matter how much you might have a colleague on the medical staff who's going to become chief of staff, no matter how friendly they are, no matter how much sympathetic they are to the emergency department, they genuinely do not understand the emergency department and the flow of things and why we do and do not do certain things. It's not a diss for them. I don't think it's possible to. It's just amazing. I brought this up in one hospital when I was chairman of the emergency department, and they said that there was going to be they want to know who's going to be chairman of the emergency department committee. And they had a bunch of surgeons and some internists and all that kind of stuff. And I said, oh, that was good because I was kind of tied up anyway. I was going to apply to be chairman of the surgery department. And they looked at me and I said, well, why not? They said, well, you don't know anything about that. I said, yep, that's the reason you can't be the chairman for our department. And this is a long time ago before emergency medicine had made its mark in things, but they just don't understand why we can't do or not do certain things.
A lot of these have a common thread, rapid medical evaluation, doctors in triage, and some of the nuances of how they do that. How many of you have a doctor in triage? Oh, really? That's unusual.
What's your ED volume? 70,000. Okay.
I thought it would be more people than that, because this idea of pushing doctors from the department out to preemptively strike in the waiting room has been, I hear a lot about it.
Or mid-levels.
My concern about it is, where's the next step? Let's put the doctor in the parking lot, So I think it's a workaround for the fact that you can't see them in the back where you have there may be some more privacy, but it seems to be. I've heard stories that were very successful, and I've also heard stories where it didn't work. I guess it's all in the details of how you make these things work.
I think every department has its own limitations. Some are space limited. They just do not have enough rooms to handle the volume, so they take triage as a assessment and treatment room, and if they can get them gone without actually bringing them back, that works for them. For some people, they're bound by the fact that their hospital is just full all the time. And so they have all these workarounds with bed availability and send the patient up to the floor instead of having them wait in the waiting room, have them wait on the floor in the hallway until the bed's available. I think all these things just depend on what's your slow part. In some, it's getting the labs to the lab. The lab is fast once they get them, but there's some sort of breakdown in the process before that.
This person has a 3-2-1 rule, which means less than 3 hours to make a disposition. You have less than 2 hours for the consult and less than 1 hour to find a bed. That's all great, isn't it? That's terrific. If you could enforce any of those or have administration behind you to do it, I think that would be terrific.
Well, we mark down on the chart the time of the admission decision so that we can quantitate how long we're taking care of floor patients in terms of that work, because it's fashionable to criticize you because you're overstaffed or you're not, and you have too much staff and you have to put them off. But the fact is, if you can show that this person was held in the emergency department 6 hours after a decision was made and all of that work associated with that, then you can help give the data to support the case that no, you're not overstaffed. So this decision time to admission time, I think, is an important time to be able to document. Our goal has been 1 hour, and in the year 2000, for 1 year, we achieved 1 hour from the decision time in. Now we're basically at 2 hours, and it's it's held us up. We want these beds empty for new patients.
You know, I actually only half finished my earlier rant. I got on the Joint Commission rant. I didn't mention about CMS. So if they just said that if you're admitted to the hospital and the decision, from the time the decision to admit until you actually get to the floor is more than, you know, pick a number, 8 hours, 10 hours, they can't charge for the first day. Think about what that would do to hospitals. They would just lose that, or they lose half of the DRG, or whatever the financial penalty is. That would just solve our problems. Because I think what Rick has said is, if you want to know how to make your place better, you have to understand how they do accounting in the hospital. It's a very artificial system that was invented when there was cost plus kind of stuff, where they wanted to make the ER look expensive kind of thing. I spent 2 years with a hospital chief financial officer because he always kept saying the ER loses money. I'd say, okay, close it. He said, we can't close it. 80% of our admissions come through the ER. I said, then your accounting is wrong. You know, there's something that's wrong here, that if you credit radiology with all the CAT scans that we ordered and they get all the money for it, no wonder they have so many techs and great equipment and all that kind of stuff. That ought to be our money, and that's why doctors are putting in their own CAT scanners.
Well, speaking of CAT scans, here's one from Sarah from Australia. If the surgeons request a CT abdomen, sometimes without examining the patient, then the patient is admitted under them pending the CT and decision. That's interesting, to just get them upstairs basically to wait for that CT scan. That's maybe that's kind of an Australian thing. Where's Sarah? You want to comment on that, Sarah?
Yeah, we had a bit of a problem. Sometimes the surgeon would take 4 hours to come down to see the patients.
Yeah.
Because they were operating when they were on tape. And their standard response on the phone will be, we'll get a CT scan and we'll see what that shows. So they now have to come see the patient, and if they want a CT scan, order it themselves. And then if we think the patient is stable enough to go to a bed, they get admitted to a bed and wait for the CT scan or order themselves.
Wow.
So doesn't that seem a little weird, though? I mean, what if he is in the OR? I mean, that's not doing the patient any good, is it?
But they have a team, they have,
Oh, I see. So he can say to the registrar, go downstairs, look at the patient, and then say order the CT scan. So is that what happens? I mean, wouldn't the resident or the registrar go downstairs and see the patient and say, I felt his belly, he does need a CT scan? Then that's okay.
well, that's what we would like them to do, but quite often the whole team is in theatre and they can't possibly spare a member of the team to come down and see the patient.
So the person gets admitted, and then what if he goes home? I mean, that,
Somehow they get to see the patient on the ward a lot faster because they'll prioritise them when they're admitted under them. It's got their name in the bed now.
Interesting.
that's great you could do that. I mean, I know in most places here, they would say, no, I'm not going to admit the patient. That'll be that.
The hospital executive has ruled as such to
Yeah, no, that's what you need,
Yeah, to
exactly.
increase throughput,
right.
it'll work. It'll
Yeah.
help. There's a huge delay of time that people sit down there waiting for these things, and if they're stable, they could wait upstairs for it, and they go home from up there.
It's actually, but from New South Wales and Australia, the actual state government has mandated that the emergency physician has the right to admit the patient. They say they get admitted, they get admitted.
Yeah.
When do the flights leave? What's the flight schedule?
Yeah.
But isn't that still true?
Yeah.
Tony?
It came out
Yeah.
of the commission inquiry, and one of the recommendations was that the physician has the right to admit.
Yeah, we
Any
have
service.
right.
And they could decide if there's argy-bargy, whether it's cardiology or respiratory, that the emergency physician will opportunity.
And then if those guys want to discharge it that night, that's their business.
Yeah, we do this. We have actually admitting privileges, the emergency
To
physicians, no, for everything. You can put them wherever you think that they should go. And, you know, in practice, we still kind of do a formality of sort of letting them know we have this patient, et cetera, and, you know, you kind of go through those things. But if you need to get someone upstairs, we have it in the hospital policy that emergency physicians can put patients on whatever service they feel is most appropriate. Yeah.
We just have it as a conflict resolution policy. If we think they need to be admitted and somebody else doesn't, okay, come see them and discharge them. And that just had to pull that one on psychiatry there. They said, well, you know, I'm not sure we could do that. I said, no, they need to come in. Well, no, I don't. I said, okay, come down, see them, and then they're your patient. Okay, just send them up. Here's an interesting one. Let's see what comments are on this. Just tell the patients they've come to the wrong place. Sometimes anxious patients come for a second or a third opinion to the ED for a non-acute problem. First, establish that there's no acute deterioration, mandatory history, but also vital signs and an exam. tell these patients the ED is not a good place for chronic condition management. Tell them they're better off with their family practice or specialist and send them home with reassurance and say, you're welcome to come back if any drastic deterioration occurs, but don't do any tests.
But do they still get charged for the visit?
I'm sure they do.
Oh, sure, absolutely.
Sure.
I guess it's an opinion. It's still an opinion.
Right.
Yeah.
I actually like it when they come and do that. To a large extent, I'm amazed at how often they're right to do it. They've been to 2 doctors. They went to one neurology doctor who said they have to see the neurosurgeon for the back pain, or orthopod, who said, you know, they're actually going to need a major operation, but the back pain actually doesn't seem that bad. Is that right? Does that seem right to me? You know, my uncle had this back operation. He was never the same. You know, you get those questions all the time. Say, thank you for coming in. You're right. You don't need a back operation. You know, go to some neurosurgeon that's not drunk, or, you know, whatever.
Here's one for zero tolerance for waiting room.
What does that mean?
What does that mean? We're not going to tolerate people in the waiting room?
Get out. Just get out. No.
Is the author of this thing here?
Maybe that's just, you just bring them directly back.
Yeah.
You don't put them to the waiting room. Or if instead of waiting room, they wait in a chair in the emergency department.
Yeah, that's kind of a new trend. People getting sort of the recliners or more chairs, and
Yeah,
you know.
instead of having the chair in the waiting room, they got the chair in the ER. That's a lot better.
Yeah.
Well, that's the idea of the secondary waiting room, where the concept is nobody owns their bed. So you go in there and you put the person in the bed with the ankle sprain, and they own that bed till they leave the building, and that's considered not a good use of that bed. So the idea is the secondary waiting room said, okay, we saw you in private. You needed to get an x-ray of your ankle. Have a seat over there. The x-ray tech will pick you up, and that, in the meantime, that bed is then used for somebody else. But fundamentally, you don't own your bed till you physically leave the building.
There are some hospitals I know, not mine, but like Maimonides in Brooklyn and Jersey Shore, on the Jersey Shore, where they basically, as I understand it, only use the rooms for examining people. Otherwise, you're in the hall. That's what it is. You don't own a room either, you know. So if you come in, you got belly pain, that's fine. You come in, you know, they draw your blood, you do whatever, they put you in the bed, they examine you there, feel your belly, you come out, you go back in the hall, and somebody else goes in that room. And I think that's part of it.
They have these internal waiting rooms for the people who are waiting for their stuff to come back, but who don't need to be in a bed.
And certainly not in a room.
That's what I kind of mean, yeah.
So that's obviously a place that's bed-bound. I mean, they just don't have enough rooms to keep people in them.
Right.
And some will have that problem. And so you can, actually the people who talk about having them wait in a chair in the waiting room to be seen, instead of sending them out to the waiting room, say, you know, it's very uncomfortable for doctors to be walking back and forth and the patient kind of like, you know, looking at you and that kind of stuff. They wind up seeing them sooner because they take ownership of getting them seen sooner. Well, here's a couple things. Fast track, we've probably covered that. Floor holding, okay? So what that concept is, for those who haven't seen Peter Viccellio's stuff, is that, you know, we get somebody who's ready to be admitted, and we don't have a room for them on the floor, so we put them in the hallway of the emergency department. We take care of them there until the bed is ready. Say, well, why can't they do that on the floor? Just put them on the floor, and then all of a sudden, beds become magically available. And so he's instituted this in his hospital, and he's done studies on it, and he's shown it's safe and all that kind of stuff. That makes the hospital take ownership of the fact that there are no beds available. It's not an ER problem anymore. And, you know, it starts at a certain number of holders, I don't know, 5 or 8, something like that. Then they put them upstairs. Yeah.
My facility, you put a patient in the hall, the patient satisfaction is not very satisfactory.
That's been shown.
And, you know, they don't get attention, they don't have any privacy. That's not going to work.
Well, what happens is they can't use the ER room because they don't need it anymore, and other patients need it. So they're going to be either in your hallway in the ER or the hallway in the hospital ward. And once they get to the hospital ward, they get admitted faster, I think is what it amounts to.
Yeah, Peter just published his study a couple months ago, and once they get to the floor, the nursing station, and they put a little screen around them, the majority, something like 80%, were in a bed within 1 hour, because nobody liked them there, and the nurses particularly, and so they expedited the cleanup, or whatever the issue was. They were more engaged because that person was sitting right in front of them. And Peter's view is their hallways are nicer than our hallways.
Adding nurses are nicer than ours.
Adding additional exam rooms. Well, that's a problem. It takes forever to, you know, make a new ER. so that if you can't make a new ER, you have to go faster in the one you have.
And not only that, you'll probably remember, recently there was a study that looked at it, and under some scenarios, adding the rooms, I know this sounds a little strange, would actually make things worse. Similar things, it's a mathematical model, have been shown actually with adding things like bridges in traffic patterns and stuff like that in cities, where you might think if you added lanes or added bridges or added roads, it would always make things faster, but it actually doesn't. And under the scenarios that they looked at, adding rooms was the worst thing you could do, adding rooms to the emergency department. The best thing you could do would be to either add rooms to the hospital or shorten the hospital admission stays.
This doctor also says that increasing staffing, docs and PAs, I believe that ERs need to be luxuriously staffed. Patients pay a lot to come there. We don't seem to value their time. And the staffing of using techs, techs are $20 an hour. Clerks are $20 an hour. One patient who comes to your hospital is worth a lot of money. I know a hospital that says, and has calculated, that for every patient who goes home, that hospital collects $749. So,
I mean, they don't collect.
No, they collect $749 on average for every patient who goes home.
You mean discharged?
Yeah,
You mean
goes
seen and discharged,
treated
right? I
and
thought you meant
discharged.
not seen.
No, treated and discharged, not admitted, $749. So you would never be in a position to say, oh, we can't afford another tech, because if you have one left without being seen, that will pay for like 3 techs for all day if that happens. And all of us have left without being seen, and the national average, I believe, is around 3%, which is pretty abysmal when you think about it. That's 1 out of 33 patients goes home because you've made it so impossible to be seen there. Limited triage, that's cool. None of this medication reconciliation and all this other stuff, and toilet training and learning preferences and religious preferences and head circumference and all of that other stuff out there. Hospital began a hospitalist program. I think that would be really cool to have one at our hospital. And we have yet to go to an EMR. I believe that this has improved our throughput.
By not going. I
By
think.
not going,
Yeah,
yeah.
I mean, probably right about that.
Any others?
How about
Well, there's,
discharge
discharge lounge. Here's
Discharge
one with
lounge.
the discharge lounge. Again, this is back to sort of a specialty area where the patient doesn't own their bed, they're waiting for results, they're not sick enough to need to be under direct observation. That's worked in a lot.
Anyone have a discharge nurse, a specifically designated discharge nurse that floats around and does discharges? That's something that comes up sometimes, an idea of, that one bottleneck is that people are just waiting too long for discharges, and maybe having somebody who's dedicated to just getting those people out and prioritizing them. That's something that's come up before.
It's been looked at as it's the lowest priority
Yeah.
because obviously they're done. They obviously don't need care, and we have patients who need care, so they don't get prioritized very well.
Well, some of the places have this thing where you get an admitting nurse, so that the nurses on the floor don't have to go through this big upfront kind of thing where I don't know if you see a person go into the hospital, they ask all of these ridiculous questions that they put into some database about when was your last bowel movement. It doesn't matter what you're there for, they're going to ask you about your last bowel movement like that.
Right, and were you abused by your spouse while doing it?
Exactly,
I don't
you
think
know.
that that's necessary.
So-
But I think you had a story. Did your spouse, do you know how many times the same question is asked? I mean, the allergy questions,
God.
the questions about family history, the questions about medicines, and it is clear that we're not listening. You had an experience like that, I think, right, with Diane?
No, it was my kid who had a little minor surgery, but honest to goodness, at least 4 people asked that same question. Nobody read anything that the other person had put down, because obviously a drug allergy is the worst possible thing that you could have when, they all ask it, and a lot of redundant stuff. But now you see the Joint Commission in the States also wants you to ask these other questions. In California, it is required that you ask about spousal abuse, and it's also required that you report it whether the patients like it or not. Well, whether we do that is another matter, but the fact that they use the emergency department to be this societal safety net of all of this stuff, you're asking people who come in with a cut finger, who's beating you up. It's like, that's really none of your business. I'm here for the cut finger. And so there is some issues about that. And plus, the Joint Commission has this thing about nutritional status. You ever see that? That's one of the boxes on the triage thing. They want, I've never seen one of our nurses say, you're too fat. They don't, they just put
Well,
everything.
that would be the pot calling the kettle black, so they probably don't do that. Also, the immunization thing. Don't you have to ask if they've been immunized against child abuse?
Your update on your immunizations. Learning preferences. You catch that one? Yeah, well, I'm kind of a visual learner, you know. Okay, we'll make your aftercare instructions with a crayon, you know, to help you
If
out.
you say you're dyslexia, I think they're required actually to give you the form backwards. They have to give it. It's a new.
In 12-point print.
You know, one interesting thing I know a local hospital does is that if you look at your patient population for most of us, and you can look back about 5 years, about 70% of the patients that come to you at least have been seen in your system before. And so that you have information on them. So they've cut down their registration process to, you've been here before? Okay. Your home number the same? Fine. We'll call you when you're done and see if anything changed. And then they go in and see them.
A lot of electronic stuff, you know, computerized stuff can do that. They can kind of like repopulate with the past information, that kind of thing. So some of that might go away.
Yeah,
with
some of
better
it's the
systems.
downside. I'm sure you've all seen that, where, you know, you have the wrong LMD, right?
Right.
You know, and that's because, no, I haven't seen him in 5 years. My insurance changed. You know, so there's two sides to it, but of course you don't have to repeat everything.
Yeah.
Well,
Yes.
You never know when that's going to
there's
change.
also a thing, you know, we're near the East Village, so the thing about gender, you know, the whole thing about gender might have changed. You can't tell.
Any others?
Well, here's another takeoff on what's been mentioned, a rapid assessment zone, a shift in the early afternoon, staffed by one doctor, one nurse, you know, that they get the patients going. We've actually instituted sort of on a call-in policy. If you're going to call another doctor in, you have to sit down and say, are we going to have another nurse and another tech called in with them? Because for most of the time when you need an extra physician, they come in and they have no support. They can't have people enter orders into the computer. They can't get them to put on splints. They can't do stuff. So we've had that unless you're going to call a whole team in, don't call one.
Well, we have the same thing. We have a doctor on call. He gets paid to be on call. They don't like to be on call, but we're a one-doctor place with a PA and an NP sometimes. So we have this doctor on call in case there are surges or the patients are particularly sick or whatever reason, that doctor's pay is not affected by calling somebody else in to help him or her out. But the hospital is not, they don't have anybody on call, and they choose not to do it. It's like this is one of those things where they really don't appreciate the value of ER patients in terms of their revenue because they don't want to pay a nurse to be on call or a clerk or a tech or they have the plan where they're going to bring them down from some of the other places in the hospital where they're not very busy. Well, they bring down people who don't know a damn thing about the emergency department and they're fairly useless. And that never works on the nights or weekends. And so it's really not a very successful endeavor.
Yeah, we were told that every patient we admit, you know, on average makes $10,000 for the hospital. So, you know, we admit 20,000 or something like that in a year. You know, that's 20,000 times 1,000, it's $200 million. That's what it gets. And, you know,
so anybody here, anybody make any unusual changes during the H1N1 stuff, just relative to the H1N1?
Well, here's one, because Josette wrote about this.
Okay.
They operate a flu clinic from 8 a.m. to 11 p.m. based on influenza-like illness symptoms for 2 to 3 weeks during the flu surge, staffed by an ED doctor and a resident who was pulled from a floor rotation, and a nurse for patients not expected to need hospitalization or extensive workup. How did that work, Josette?
Really well.
Yeah?
We went from about 16-hour waiting room wait times, where we doubled our record in like a day as far as the number of patients that showed up for private enroll, to it becoming like a regular sort of busy day.
Can you imagine being the doctor assigned to that? Oh no, don't put me in a flu clinic. You know, God, it's like.
Moonlighting hours, and actually some of our more mature staff who don't like to do nights and things like that and moonlight, were able to get a little extra moonlight money.
I don't know, if I was,
To get the administration to buy into it, but it didn't take long after we chased them out of the
if I was the resident, I would complain to my RRC about that. You say you're going off the floor to see these patients in a flu clinic? Sounds a little bit like abuse.
Anybody else do anything special?
Yeah.
Was this in Texas? Yeah, I remember reading about that.
Pictures, you got great publicity for that too, you know.
I'm surprised.
Yeah, go ahead.
Wow.
That's perfectly kosher. No problem.
Can you imagine being the one sitting next to the guy who was coughing on you? I guess I can go home too now. You know?
I guess there would be some issues about a good faith medical examination under that. I'm surprised nobody is whining about their electronic medical records. Or are we just all resigned to it, that it's just inevitable and we're going to go slower? I mean, there used to be lots of whining.
Yeah, go ahead.
We put ours in 3 years ago, 4 years ago now, and they rolled it out to EP, which is a wonderful thought. And it slowed our productivity down by about 30%.
That's what everybody says, that number.
We've come back up. We're still slower. We're still probably 2 patients a shift slower, so that's probably 10% slower for our docs. There's great things about it, all the old medical records, their last medications from the last visit, all that stuff, and being able to look back and see your previous stuff is terrific. No longer trying to get those big, huge paper charts in. We recently went to all physician order entry, which has been horrible because the clerk can order CAT scans so much better than I can. They get paid, a tenth of the money. So that was a ridiculous thing. But they just recently made all of the doctors on the floors do it. And we have had almost half of our doctors drop their admission privileges. And
Really?
our hospitalist group is about full because of it.
What system do you have? What system do you have?
Epic.
Epic. Yeah.
Which cost our hospital, when you guys were talking about the cost before, $44 million over 5 years, we still did not have the 2008 upgrade. So if that tells you how great of a system they are, hospitals looking at it.
Yeah.
Yeah, comment. Yeah.
We have an electronic medical record. What we do is we pay the docs to chart after their shift if they need to. So that way you don't get slowed down if they're in chart during their shift. So if you chart at home, you can go with that too.
But it's all the order entry.
Yeah.
That's what slows us down.
You can do the order entry after the shift. That's right.
When you do the before time.
But, you have your administrators, you guys build that exactly how you want. And so that's what you need to take back to the programmers and say, look, the programming is horrible, something needs to be done with that, because that is something that you pick and choose exactly how you want things done. And if nobody likes it, then the programmers need to know that they like it, because spending $44 million, that's also not going to get rid of it, and spend another $44 million to change to something that's better.
We have a doctor where it's almost half-time just doing it. And getting them to respond to the simplest of things has been tough. I mean, we have had, he works half his time doing only extras.
I think some programs have never done that. We use IBAC, and it is truly the easiest thing ever. Well, it's just as easy as writing myself. It really is.
Everybody hear that? What's the name of that? IVAX?
IBEX. Yeah, IBEX is pretty
IBEX.
good.
It's fabulous. And they will do just what you said. They'll order sets, whatever you want, they will build. Even with macros.
Although there's a move away from that stuff because they don't want the best of breed for emergency departments. They want a common system that'll work throughout the hospital and the clinics and things like that. And bolting on an IBEX or a MedHost onto the hospital's Cerner system is always viewed as a pain in the butt.
So the problem I have with we'll get to yours in a second, is so you have IBEX and you have Epic. If somebody goes to your hospital that's been to that hospital, can you get their records? No, not at all. What you do is you get a printout from their record that is completely indecipherable. I'd rather have, so we sit between the University of Michigan and St. Joe's hospitals, both of which have electronic systems. And if somebody's been there and I try to get their records in, it's indecipherable. It's, there's a time and the nurse's initials and the blood pressure, and then the next thing is a comment about domestic violence screening, and then it's a lot. You can't go through it. There's no order to it. I would rather a handwritten record to come and say they came in with a sprained ankle and we sent them home, kind of stuff. It's amazing. Go ahead. I didn't mean to interrupt you there.
Yeah, I don't work for Epic, although I like to work for Epic. But we did just implement Epic at our hospital about 4 months ago, and our productivity went down and it's come back up. But I can tell you that if you use Epic the way that you can use Epic, you really have to customize it to the way that you work. You will be much more efficient. In our prompt here, I can see almost 7 patients an hour utilizing Epic with CPOE and be done on
How do you pick those people, though? Is that just
You don't make them. You have to find them. You have to train them. You gotta go do residency programs. And I was in a residency program for about 10 years. And residents would come up to me and they say, "Well, I want to order this, and that." And I would challenge them. I would say, "Okay, so when that white count comes back at 20,000 in that acute gastroenteritis patient, what are you going to do about it?" And they would say, "Well, I don't know, call the service." I said, "Well, why the hell would you call the service? The person is 18 years old, he's puking. He probably doesn't even need to be here. So why would you order it?" And I think that's what we need to do, is go back to our residency program and say, "Look, the docs that we want are the docs who can walk into a room, listen to me, truly listen to me, examine me, and then say, you know what, you don't need anything, and get them out of there." Until we start doing that, our workflows are going to be backed up.
Yeah, well, the problem is, I agree with you 100%. Many, probably most of the docs in the residency programs, I have no reason to think that they are any, less risk averse overall than our docs in community hospitals. Maybe the opposite, actually. And it's a very frustrating thing. I actually think your risk averseness, and there's a couple of articles on this, I wouldn't say it's exactly inborn, but it almost seems to be, and it's very hard to change. We've all seen docs like that who do that thing, that order, and then when the test comes back, then they order something else. Very hard to change that. The articles we have in the database say that although there are big differences in risk averseness and risk taking, there's the ones who take the more risks are not sued more, and there's no evidence that their outcomes are worse. I think they're better. I think there's no contradiction between being confident and smart, knowing what you're doing, and doing efficient medicine. It's the person who isn't like that that's doing all the rest of that stuff.
Yeah, maybe you need some kind of psychological profile of these doctors before they come on to see where they fall, because it's interesting. I think there is a tendency for risk-averse doctors to work in the safety of a university. That might be a little prejudicial, although at our hospital, one of our doctors who works part-time is full-time faculty at University of Southern California. He orders a minimum of twice what the other doctors order, and sometimes it's 2.5 times, depending on what the test is. Extraordinarily risk-averse. And what he does is, I think in his training of other doctors, is teach them to be risk-averse.
we're not all
Have you
like
spoken to him?
Be forced upon us because I'm now on the other side of the fence because I'm part of hospital administration. But what we're doing now is we're looking at the costs that all doctors are having on the hospital as a whole, and saying, okay, what kind of doc do we want to have on our medical staff? Somebody who takes care of pneumonia patients and spends $4,000 taking care of that patient, or somebody who takes care of pneumonia patients and spends $2,500.
Which do you want?
I can tell you that, your statistic that the hospital gets $20,000 per patient isn't nearly what we have. What we have, and we really digested this, is we have a system where we have probably 55% of our patients are Medicare patients. We've looked at the cost. This is not the charges, this is true cost. We get paid 79% of what it costs to take care of the average Medicare patient. So essentially what we're doing is we're losing 21% on every single Medicare patient, which is 55% of what we take care of. And the ones who used to be really good patients for us to take care of, the spine patients, the elective orthopedic cases, what's happened is the cost of taking care of those patients is skyrocketing because doctors are doing all kinds of things, using all kinds of biologics and expensive items on them. And we're looking at them saying, you know what? If you want to leave our hospital because we went to an electronic medical record, sign ours because we get losing money on you even in the OR.
I was going to say, the idea that you need to hire the right person for the right job. I know several places that tried to put in bedside registration, and until they fired all the fat old registration clerks, they couldn't do it. Because they figured, wait a minute, the patient is ill, I'm healthy. Who should go to whose room? I should go to their room. They didn't figure that was their job. Their job was to punch data into the system and not try to help throughput. And so they worked with it, and they finally just said they had to get them all jobs elsewhere in the hospital and get people who had a different opinion. Yeah.
Yes.
Following up on that lead, and I've worked on the same side, on the bad side
The Marshfield Clinic needs to publish your don't make a start with a blank piece of paper. You know, it would be real helpful if somebody could see that, share that, and adopt that kind of thing, rather than, it sounds like a daunting process to begin from scratch if you don't do that now. I'm kind of surprised that nobody in his papers mentioned scribes. Not one soul mentioned scribes. Anybody use them? Anybody think they're cool? So there's 3 hands in the room that uses scribes? That's hard to believe.
Scribes might be a good idea for your group of people, because having worked at a hospital with scribes, for he's aware, those scribes, those are pre-med students who are 18, 19 years old in college, and those guys know exactly how to work everything. They can design everything to work. You know, in a position specifically, and they're not taking while they're cutting their HMP. I mean, they're a heck of a lot faster.
So scribes are good or not?
$7.25 an hour isn't a whole heck of a lot of money.
How much?
$7.25.
Whatever minimum wage is in there.
And a recommendation for their mid-school application.
Exactly.
Right. Priceless. Priceless. That's the priceless part.
We had a scribe. He actually started when he was a freshman, and by the time he was his senior year, he could read EKGs just about as good as anybody else. He has to go to an application. They actually go with knowledge in school that no one else probably would have.
Yeah, they learn a ton and they love it. And it's fun to have someone to teach too, you know?
Yeah.
The biggest perks,
50 scribes.
What department is that?
In our emergency department, we have 50 scribes. They work about 25 hours a week because they get the letters written. But it's an extra set of eyes and brain. So as the labs are coming back, as the mark comes back, if you need to find out that the results of a typo a week ago, I don't have to go log into a computer. They have a computer on wheels. They pull it up and they show it to me. And we talk about it with the patient in front of them, so the patient can see, here's your numbers, here's the prior results. And they love it. Patients love it. And they type down the HPI and they print the paragraph down to what's important. And they cost about $1,200 per scribe per month. And they probably give us an extra 2 patients per shift added per doc, because we also carry on a dictum phone. As soon as we have a room, we fire off a medical decision making and the scribe they put in their notes and typed up. If you're going to go put in a heartline central line intubate, you 3 quick dictations hand to the scribe, and they watch you from the window. They learn all this stuff. They love it. They learn how to do reductions in CPR. They really see stuff. And patients, no patient has ever complained about the scribe being there. They think they're really part of something serious. If there's someone coming in with a computer on wheels, that must be important, and so
It's like a personal assistant.
it's perfect.
Yeah.
It's money well spent. I mean, it's cheaper than half the tech.
This in a busy community hospital setting?
Yeah, but we have a lot of colleges in the area that have a lot of pre-med students that all of our limited space in med school. So they get 2 years of great experience, and they start off med school like 3 med students.
2 of our scribes are doctors from third world countries waiting to pass whatever this exam is that they take, which is like apparently a hard exam. They keep on taking it over and over and over again, you know.
Well, that's
I'm
only
hoping
one
that-
possibility. It's a hard exam. There's
It's
a
good.
second
It's
possibility.
because they can't speak English, Rick.
Yeah.
They're your scribes, the ones who
Usually
don't
that's right.
understand English. Right.
Unfortunately, some of those scribes are writing from right to left, but you know, it's up to down.
The only thing our scribes can't do is they physically can't put in orders. They stopped that a couple of years ago. Actually, the scribes were logging in under our log.
Sure, of course.
So they could put in orders, and
Well, apparently scribes cannot do the HPIs. I heard that from a number of people.
They can physically.
No, they can't. It can't be in their words.
You mean they can't take it from the patient and write it in, but you can tell them what to write.
They can't generate it themselves.
So that, our scribes have laptops, and we go from room to room. The only problem is, like I said, you go from the next room, you want to put some orders on that last patient, so a couple of our docs have gotten little web books that they actually carry around with them and log into the web, just to put in orders as they're going to the next room. Supposedly, they're coming out with a phone, that iPhone app or BlackBerry app too, that you can just kind of carry and put in orders. So like I said, you don't have to necessarily go back to a desktop or another computer to put in orders. And that's all on that demonstration.
Well, let's pick one here. These are not based on. This winner will not be based on merit.
Thus, mimicking what happens in life.
All right. Neil, you want to do the honors?
Sure.
You need to be present to win.
Judy McCarrick, Inova Fairfax Hospital.
There she is.
There you go.
Look at that.
Although it wasn't based on merit.